Hello everyone, my name is Josh Hodges. I'll be discussing my project, the analysis of adherence to prostate cancer screening guideline within a primary care setting. In the introduction, prostate cancer is the most commonly diagnosed cancer that affects men in the United States, next to skin cancer. Prostate cancer is also the second leading cause of cancer-related deaths in men. Prostate cancer affects men of all ethnicities and socioeconomic backgrounds. The lifetime risk of developing prostate cancer was 16%, and the lifetime risk of death was at 3.4%. There have been different opinions and much confusion surrounding PSA testing for prostate cancer. Therefore, the United States Preventive Task Force, or the USPSTF, created guidelines for PSA screening. Men 70 years of age or older have been given a grade D when it comes to PSA screening. And this grade essentially is meaning that the age group of men are not recommended to have PSA testing due to the high risk of harm over the benefits. And so essentially, PSA can be increased due to a number of things other than prostate cancer, such as prostatitis, UTIs, and BPH. So the issue is, even if one of these illnesses or disease processes cause the elevation of PSA, the provider continues into treatment modalities and begins to implement these. And with this older age group of men, they are at such a higher risk for urinary incontinence, infections, bleeding, and erectile dysfunction after any of the treatment modalities. And the purpose of the study is to compare the rate at which men in the mentioned age group are still being screened, regardless of the current recommendations laid out by the USPSTF. And the objectives, the primary objective of the study is to interpret if a rural clinic in Arkansas is following the best practice recommendations on PSA screening in men 70 years of age or older set out by the USPSTF. Depending on the compliance or lack of the compliance set out by the guideline providers in the clinic may be able to save revenue by not ordering an excessive amount of PSA screenings if it's not indicated. This may also prevent unnecessary harms to the patients due to the risk. And the method used was a retrospective chart review. This study utilized IRB through Arkansas State University, and the study was implemented in a rural family clinic in Paragould, Arkansas. The data was collected through 50 randomly picked charts of the specified population, and the dates were January 1st, 2020 to February 28, 2020. This was the time frame in which the research was conducted. Under a population, the charts were used in the study include male patients, of course, who were 70 years of age or older. The charts were manually searched for the diagnostic test of PSA screening. Females, of course, are a total exclusion criteria, along with men under the age of 70. In the findings, the study showed that the rate of men screened who were not recommended to be screened due to their age was actually 74% at this clinic. The other 26% of men were not screened using PSA, and that actually does follow the USPSTF guidelines. So, under the discussion and action plan here, as far as following the grade D recommendations set forth by the USPSTF on the PSA screening, the clinic in Paragould has quite a bit of room for improvement. The majority of the patient population that was reviewed were being screened unnecessarily, as set forth by the USPSTF. And this may lead to a loss of revenue for the clinic and can cause preventable harms to the patient, which may then incur even more loss of revenue. Provider education and staying current on USPSTF screening recommendations is advised as part of the action plan for this clinic. And of course, education to the patient population as to why we wouldn't screen and why it's not recommended for their age group. And then, of course, a discussion about the harms versus benefits for the screening. And as far as acknowledgments, I'd like to acknowledge Dr. Foster and Ms. Hadley and have references available upon request. Thank you.